you are operating again?
Yeah, yes, sir. Second case I'm doing.
You seem to have changed the machine, right?
I've changed the machine.
So can we have the microscope view, please?
Next, I think Dr. Sandhya will just introduce the case once again.
Second case is a
இல்ல,
50-year-old
என்ன பண்ணாரு?
lady
It will take
with a mature cataract in the left eye. We're planning to put an eye hands in the left eye. The first case, the nucleus sclerosis was not, the nucleus was not very hard, but in this case, we have got a hard nucleus with a mature cataract.
Thank you. Thank you.
Microscope view, please.
Yes, Sai.
Is it visible, madam?
Yes, perfect.
Why do you say it's a hard cataract? It still looks.
No, it's not very hard. It is slightly harder compared to the first case.
Okay.
Not very hard.
Yeah. What do you put? Is this Phenocaine or something?
No, I put Phenocaine plus for all cases.
Okay, so this is Phenocaine plus. Can you tell the audience what is Phenocaine plus?
It is a combination of local anesthetic with tropicamide and phenylephrine.
Yes.
And which is very useful for our topical cases. With one medicine, you can get both a bit of surface anesthesia as well as mydriasis. So I'm using quite regularly now. This elderly lady has got a bit of tremors. Okay. So please excuse me if you find the eye moving.
As long as you don't have tremors, it's fine.
I have to move along with her, so it's better that I have a bit of tremors.
Good.
Sir, Dr.
Actually, the point is that in India, this combination is pretty good. There's another, the one that is in US, which is Omidria, that has Ketorolac, and that costs about $100-200. It's very, very expensive. But I think this is a good service to the Indian ophthalmology to have got this Phenocaine plus, and that's a great Rexes you are doing.
Excellent Rexes, Dr. Sai, and this one you did without making it smaller, just the size.
This we can. This there is not much of very high intra-bag pressure, so we can get away with a straight Rexes without having to do a double Rexes.
So the importance of just doing it through the side port is there, and now he's making the primary incision.
Here I will make a very gentle hydrodissection. In these cases, hydrodissection should not be very vigorous for two reasons. One is the posterior capsule itself may be a bit brittle, and you can have a blowout. And secondly, the Rexes is also not very large like in an SICS, so you have to put small aliquots of Thalayanakar there. Right?
So, Dr. Sai, in which cases do you do an SICS if you still do it?
I still do SICS for very, very, sort of pearly black cataracts, where I think, it is in my hands the corneas are much better with an SICS than with a phaco. And secondly, when there is very high astigmatism, somehow I find that, especially the temporal steep astigmatisms, I find that if I soft tip a normal tip.
Why not a toric?
Pardon me, sir?
Why not a toric?
Yeah. Of course, toric is an option. That's a soft tip, normal tip.
I think I have been trying to push the companies to have differential pricing for torics as regards small cylinders. Cylinders, because then it becomes more acceptable to the doctor and the patient.
Correct. Actually, we should be doing more torics. If you actually look at the number of astigmatisms that we see, we should be doing more torics, but then quite often the cost becomes a deterrent. 3.
I also noticed that you use Viscoat in these intermittent cataracts rather than Helon. So,
rather than sodium hyaluronate. I
yeah,
somehow feel that it is retained more in the eye,
okay.
much more than the other sodium hyaluronate, which usually comes out as a single blob.
Mm.
You're absolutely right. There's one company which came to me and said that the behavior, they've launched a new, I think BS5 or something, then launched a new sodium hyaluronate which says that behaves more like chondroitin sulfate. I'm not very sure about that. But chondroitin sulfate is supposed to be much more cornea friendly than the sodium hyaluronate. Do you use Indian equivalent of
I do, sir. I do. I I use what is called Orocod Plus,
Okay.
which I find is quite okay.
Mm.
No financial interest in any of the
Products
products that I'm mentioning.
One of the important things that you are showing in the chopping is that you really don't need to go to the periphery. You just hold the center, go deep enough, and you just chop from the
Yes,
center.
sir.
So
Yes, sir. Yes, sir.
the center cracks, the periphery follows. So a lot of learners actually tend to go to the periphery to try and chop. That's a superfluous kind of a thing. See this. This is nicely shown that you are near to the center. The depth is important for the tip, and you just and you are able to do the dissection. What you have done is that you haven't started to empty the bag till the very end.
Yeah, yeah. I am very comfortable, doing all the chopping maneuvers first,
Yeah.
and then start eating the pieces one by one. Then the quad.
Are you using the Ozil?
I am using the Ozil, sir.
Okay. Do you have any observation as regards, say, in Femto or in Ozil that the pieces, small pieces, get stuck somewhere in the iris because of the horizontal movement that is there?
Yes, sir. Yes, sir. Ozil definitely.
Oh, yeah.
We are seeing small pieces and sometimes even retained, small epinuclear fragments
Yeah.
surprises in the post-operative period.
You're
After we have
absolutely
started
right.
using
That is one observation which has not been brought out. I have been
Ah.
thinking of writing a paper on it, but at times you
I have
stop
also
the
observed the
steroids.
same, sir.
Yeah, you stop the steroids and the patient flares up again and comes
Correct,
back to
correct,
you.
correct.
Then you do a more thorough examination and you see one small little teeny weeny piece stuck somewhere of the epinucleus or the nuclear piece because the horizontal movement somehow pushes the pieces to the side.
Pieces away, yeah.
Yeah, that is why in the femto laser I have stopped doing small fractionations. I do it at 1,000 or 1,500 or just
Okay,
the
okay.
6 quadrants.
Okay, okay.
Then Dr. Sai very beautifully
Yeah.
just follows your this thing, commands like a textbook picture. It comes.
Nice followability we have.
I think the Rex is fantastic in this case. This is perfectly sized. The important thing in all this is that the when we started phacoemulsification way back in the 90s, the machines have had a quantum jump.
Yeah, definitely.
Slow steadily, but now it's basically everything gets pulled. It's all vacuum based, fluidic based and vacuum based aspiration rather than using brute power to cut the nucleus.
So again something which we have been discussing on other platforms also. Ever since iHands has come, has your iHands uh, changed the way you
Vacuum correct.
practice your
300.
monofocal lenses?
Not really, madam. Eye hands, most of the patients, or at least in our institute, when they accept eye hands, are patients who initially want multifocal. And then when they hear about, halos and glare and all, then they want a good alternative. And in my experience also, the near vision, especially when you do just one eye cohevisc, has not been too great. But definitely when you implant bilaterally, intermediate vision is quite good. Cornea.
So, Sai, just my 2 cents to you. one is that the first patient that we were first surgery we were discussing as regards femto laser.
Yeah.
I think you are under leveraging the power of femto laser, because at least in my hands, my conversion is about close to 70% being
Oh,
femtos.
that's very high, sir. Yeah, yeah, yeah.
And hopefully this March we'll be possibly doing 500 femtos in a month. So
Oh
that's the
my
power
goodness.
of femto that is there. So the numbers
Uh-huh.
are actually going up very exponentially, and it becomes a kind of a cascading effect because there are so many machines in Delhi. Uh,
Uh-huh.
People come and ask for it, and
Okay.
the biggest thing is that if you have two people, somebody handling the machine outside and somebody inside, the time taken goes
Yeah,
down.
that is what I do, sir. I have two colleagues, Dr. Lakshmi and Dr. Jilu, who
Yeah.
handle my femtos. And then I actually have not gone into the femto room for some time now.
Okay.
And along with
And
me, there are a few other surgeons also, Dr. Sandhya, Dr. Vinay. They all do femto.
And the second thing is to price it right. I think when we started Femto, I'm not very sure when you bought the Femto, but we were advised to keep a differential of 50,000, which was more than
Yeah.
the delta was higher than the cost of the cataract surgery at that time. I think that was a bane. So I don't know what you are doing.
Yeah, we are also doing about 45,000 to 50,000 more than the normal equivalent non-femto cases.
Yeah, so basically you need to bring that down. That's my 2 cents to you, that you
Yeah,
need
and
down
increase
to
the numbers. Yeah.
the numbers will go up exponentially.
And then
the
the
second
volumes will take care of offset the,
Yeah, sure. And the second thing that you're talking about, the eye hands is never ever to be sold as a option
as a
for a
multifocal lens.
multifocal
Correct.
lens. We call it as a monofocal plus, and I actually don't tell anything to the patient that I'm putting a different lens, because the cost is almost the same as a single piece good lens that is there to the patient as regards the suggested retail price. So the patient is very, very pleasantly surprised that the patient does not have any dysphotopsias.
Yeah,
The
yeah.
the patient tends to get as you rightly said, the ad is lower. It's about 1.5 to 2 diopters.
Yeah, that is the,
And if you do a monovision, a mini monovision with the bilateral implants, the patient, a lot of them are able to do majority of their work otherwise. So in my practice, at least my monofocal practice has significantly been taken over by eye hands. I don't tell the patient that I'm doing anything else. So I am not telling.
But what would be your cost, sir? Suppose you compare a Technics one with an eye hands.
It's only 3,000 rupees difference in the MRP. So where the patient is paying 55,000 or the patient is paying 95,000 for a femto, he just pays 3,000 extra. That's it.
Okay.
So basically, why do you wish to say anything? Supposing I have a preloaded lens or some other lens, their suggested retail price is the same as the eye hands one. So
exactly.
You pleasantly surprise the patient for
intermediate vision.
Yes.
With bilateral implants.
Don't raise the expectations. You don't do anything. I don't tell the patient, and even if the other eye has a monofocal, there is no issue in putting an eye hands in the second eye.
Okay.
The patient says, "Doc, what have you done in this is the second eye? I can see better in the intermediate."
Sai, I think beautiful demonstration of both bimanual in the previous case.
Yeah. I just used coaxial here to clear because otherwise we'll have to keep on changing the vacuum. As I said before, I usually go for a low vacuum in bimanual.
So I think, do you have any complaints with the eye hands ever?
No, sir, not much. Yeah, because we, as you said, we never promote the eye hands as a multifocal lens. So we just a few patients that I have had who have raised significant concerns for multifocals. They have been quite happy with the eye hands, because they are patients who had significant glare before cataract surgery with thick posterior subcapsular cataracts. So when you tell them about possibility of glare and halos in the post-operative period, they are very worried, because their primary complaint in the first place is glare and halos. So in such patients, I tell them that there is a good monofocal lens bilateral implant, you might get a bit of intermediate vision. They're quite happy with that.
So I think the game, total game has changed over the last 2 years, I would say 2 to 3 years, where when with the advent of the trifocal lenses, the glare dysphotopsia has gone down significantly.
Gone down significantly,
If
yes.
you're talking
yes.
about a bifocal lens, that was true. Even
Yeah,
the
yeah,
Symphony,
yeah.
the glare halos dysphotopsia went down, but then
Yeah,
it was
but then
giving you
Symphony
good
was
reading
not
vision.
very good for near vision. Yeah.
Yeah. So I think the CRV lenses and the
Correct.
iHands are the two lenses. The only problem is that both of them are not available in their toric version just now. So once
Okay,
we have the toric version of both of them, I think they will take away
They
a
will take
significant
over
part
the.
of our practice.
Yeah. So both if iHands and Synergy come with the toric versions,
Yes.
then I think we'll have a good option.
But just to compliment you, both your surgeries were flawless, wonderful.
Thank you, sir.
You showed a lot of things, and it's really good to see steady hands. Even though the patient had tremors, but your hands were rock steady.
Very steady.
Yeah.
And there is
Okay.
an excellent viewership both on the Facebook as well as on the YouTube channel for the
Thank you.
live surgeries. Yeah, excellent, Dr. Sai.
Yeah. Thank you, madam. Thank you.